Hey folks, my name is Dr. Amy Pearlman. I'm a board certified urologist with expertise in men's health, sexual health, hormonal health, and genitourinary health. And I have Dr. Larry Lipshultz here with me today. He's here for a big meeting for GU surgeons, and I was able to get him over to our office to talk some shop. So, Dr. Lipshultz, I know you from a couple years ago, several years ago. When I trained during medical school at Baylor College of Medicine, I had this incredible opportunity to do research under you. And at the time we were studying the impact of testosterone therapy in men after they had their prostates removed for prostate cancer or had undergone radiation for prostate cancer. And I knew that research was important at the time, but I don't think I really understood the gravity of that research. So why don't you explain to people why that question was important?
Well, I mean, it was an important question because prostate cancer is hormone-dependent cancer. And so the theory was if you have prostate cancer, then you want to keep hormones as low as possible to keep it from, quote, spreading or growing, whatever. And what's come to be known now is that actually men with low testosterone are more likely to get prostate cancer than men with high testosterone. And that the fact that sometimes radiation therapy requires androgen deprivation or getting rid of testosterone, it doesn't hold true that the prostate cancer needs to be removed from all testosterone in its environment. As a matter of fact, if a patient is on testosterone for therapy because he has a low testosterone and he has his prostate removed, the oncologists that I work with now never stop the testosterone.
And that was a question I had recently asked you at the Decise at the Urology meeting. Is I asked the panel, how do you manage testosterone therapy in someone with recent treatment for prostate cancer? And I think there were maybe 5 people on the panel, and every person gave a different response. But everyone gave a different response. Someone said they would stop it, I think, for 3 months afterwards, and they would see what happened with their PSA, or they would stop it before surgery. But in your practice, you're having people continue on their testosterone therapy through treatment and after treatment. Right,
and when I call the oncologic surgeon and say, Mr. Smith is coming in, do you want me to stop his testosterone? They say, no, let him stay on it. And it was interesting because I called one of my colleagues about this, and a gentleman who was going to have prostate surgery and was on testosterone, and I said, do you want me to stop it? The man has a very high PSA. Are you more comfortable if I stop it? He said, no, because if you stop it, it's like giving him androgen deprivation therapy, and we don't want to do that now. I mean, that's not the treatment. He's going to have his prostate removed, so.
Yeah, it's interesting. And I think if we also think about it from preparing our patients for surgery and recovery, people oftentimes feel crappy or unwell when we stop their testosterone.
Always.
So if it's one thing if they never felt better on testosterone and we stop, but if they feel amazing on testosterone and we stop it, they're not going to feel well.
Correct.
So we're going to do that around the time that they're preparing for surgery and healing from surgery. It just doesn't seem like a way to optimize their healing process.
In addition, I want them to be anabolic. I want them to go into the surgery and out of the surgery in a protein synthesis state, not in a protein negative way, which they'll get if they get catabolic and come off testosterone. So, no, I think it's helpful.
So we had published that work. That was probably around 2012, 2013. So 12 years later, and we're still having this discussion, right? Because there's no way to have a megaphone.
But I can remember being in the audience and asking the people in the audience how many would take their patients off testosterone if they were worried about prostate cancer, and everyone would raise their hand. Now it's very different. So I think in general, I think the word's out that you don't have to do that.
Within urology, it certainly is. But now it's our job to educate primary care providers and endocrinologists and other specialists. Okay, that's the first topic that I wanted to discuss. The next one is on peptides.
Right.
And you've published a bit about this, and I know you use peptides in your practice. And at a lot of our society meetings, people are kind of talking about it, but not too many people are actually presenting on the use of peptides in the patient coming into a urology clinic.
Right.
And so you've published before on the use of growth hormone secretagogues.
Right.
So what might that role play in a urologist practice where a guy comes in who's hypogonadal and says, Dr. Lipshultz, would sermorelin be helpful for me? How do you have that discussion with patients?
It's interesting, but that would be a very unusual discussion in my practice because I can't remember a man who asked for peptides who hadn't come in initially for testosterone therapy. So if a man comes in and his testosterone is low and we treat him, we make him eugonadal, his testosterone's normal, he feels good, and then he may ask about peptides. But I've never given peptides, although I'm not saying you shouldn't or can't. I've never really given peptides to someone who did not come in initially for testosterone.
So you're initially treating his low T.
I am.
Okay. So then what role might something like sermorelin or ipamorelin play in those patients?
Well, they're all derivatives of growth hormone, but they've been specially selected so that they have certain endpoints. For instance, sermorelin initially was marketed for HIV positive patients who develop mid-bodies obesity, centripetal obesity, because that happens apparently with HIV untreated patients. So that's why they started using sermorelin to reduce this fat deposition in their midsection. So I still use it for that. And I give it to the patients at bedtime because it also helps them sleep. So that's why I would use that. I don't in my own mind yet understand the subtle differences between ipamorelin and sermorelin, and they're often combined when we get them from the compounding pharmacies.
Okay. Are there other peptides? I know you could say ABC 1, 2, 3, right? With all these different peptides.
There's so many peptides, and I don't claim to be a peptide expert, but I know I try to classify them in certain peptides that are good for people who want to gain weight, certain peptides that may be helpful for people who want to lose weight. But other than that, I don't try to differentiate the subtleties because in all honesty, they've not been studied well enough. They've not been studied by people who know how to conduct prospective, placebo-controlled studies, so we really know what we're accomplishing. So I like using a couple of them, but I don't use every one that's on the list. And you can go to a compounding pharmacy and see 20 of them.
Yeah.
And when you try to understand exactly when to use them, it's difficult. But I think trying to distinguish whether you're going to use them for increasing size or decreasing patients' body habitus, that kind of is a good categorical way to think of them.
And it seems to really require a nuanced approach because some of them will increase hunger and have those effects where you have to eat food right away. So you definitely want to know what you're doing when it comes to those.
I had a great one. It was GnRH2 and GnRH6, and they made patients ravenous. And the patients really liked it because some people, they want to eat, but they just don't feel like it. This you cannot stop eating.
Yeah.
So for people who were trying to put on weight, it really was very helpful. And then the FDA took them off the market, so we can't get them now at all.
Yeah. It's interesting you say that because so often now in the media we're talking about how do you suppress appetite. But for people who want to gain weight, that is like a full-time job.
It is.
Yeah.
And the people who can't put on weight really just can't put on weight. They're ectomorphic. I mean, they're thin and they just have that skinny body habitus. It's very hard to put weight on them.
Yeah.
If they come in with a low testosterone, that gives us one way to increase muscle mass. But if they come in with normal testosterone, that's not an avenue we go down. And then we just have to look at some of the peptides. And as I said, the really good ones for hunger have gone. There is one called MK677, which originally was developed at Merck. And that is a really good one, I think, for increasing hunger right now because it's a pill. They take it at bedtime and they just eat the next day. They get very hungry the next day. It doesn't wake them up in the middle of the night, as you might think. It's just the next day.
Interesting.
Yeah.
So the last topic I want to delve into is for men who are on testosterone therapy who now want to have children, right? Because that is a very polarizing topic, and in our guidelines, and we say if anyone is ever considering, right, current or future fertility, do not put them on testosterone.
That is true. That is in the guidelines.
Yeah. But you
I did not write the guidelines.
But you recently published some work looking at men who are on testosterone to see if putting them or giving them FSH and HCG can improve their sperm parameters to, potentially help them have a child.
Yes.
And so some people might say, well, duh, just take them off testosterone. So how did you get people to enter this study to stay on testosterone, and why would you keep someone on testosterone in this
Right. Well, first of all, it was a retrospective study, so I didn't talk people into taking it. They just, we started using it because people would come in on testosterone. They will have stopped their testosterone because they knew that it was suppressing sperm production, and they were feeling terrible. But they were willing to feel that way if it meant that they could have a child. And so what we found out by giving them commercially available HCG and FSH at high doses, we could replace the hormone that the testosterone was suppressing, the LH and FSH from the pituitary, and we could reestablish sperm production. So that was the initial direction. Once we found out that we could reestablish it, we started asking ourselves, well, why are we taking them off of testosterone when we're basically doing an end run around the testosterone? So what we found out was that the sperm density did not change if we added back testosterone. And then it became, well, we'll just leave them on testosterone and we'll add the FSH and LH. And indeed, we got really good results. And that was really what the paper ended saying, is that you don't have to stop testosterone. You can, if you want to give gonadotropins, LH and FSH, you can continue the testosterone.
Now, some people might say, because this work was recently presented at another meeting by one of your colleagues, and so someone in the audience said, well, why don't you just take them off testosterone and put them on Clomid? So why wouldn't you just do that, Dr. Lipshultz?
So Clomid works by fooling the pituitary to thinking there's not enough FSH and LH, and they produce more FSH and LH. The problem is, number one, it has a estrogenic isomer, which somehow negates the positive attributes of the drug in terms of increasing your androgen response. So I never liked that about it. And I had worked with a company several years ago who was trying to bring to market a drug that just had the isomer that had the androgenic properties, and that's now called enclomiphene, and that's readily available in most any compounding pharmacy. So we started using that. If we're going to use anything, we will use enclomiphene. But if you give 10 people clomiphene, this is in my experience, if you give 10 men Clomid, they will all have an increase in their testosterone. Only one or two will tell you, hey, I really feel better. They just don't feel it. And I think it's the estrogenic isomer, but I also think it's the fact that they don't get their testosterone high enough. So by giving the testosterone and then treating the problems with suppressing gonadotropins, by giving them gonadotropins, we've accomplished everything. We've restored sperm production. We've given the guys the ability to maintain testosterone. And quite honestly, when you stop testosterone in a patient who's on testosterone, because otherwise he would be low, he feels terrible. And some people would say, some physicians would say, well, just let them come back on their own, which they will do if you wait up to a year. And you know,
and they're going to feel terrible during that year.
They're going to feel terrible. And they're not going to like you. And you're their doctor. So, you're there to help the patient. So we found out this is a win-win situation for our patients.
So it seems like the message is, this is not going to work in everyone, because there is a cost, right? There is an expense, and that's probably the biggest limiting factor when it comes to FSH and HCG.
It is.
But for the man who just feels better while being on testosterone, that wants to expand his family, it's not a one-size-fits-all approach, and there are nuances in our ability to be able to treat that patient and have him still feel well in the process of expanding his family.
Now, I will say they will feel better on the HCG than they would have felt on just the Clomid. But you're not going to get your ideal sperm production by just using HCG. Having said that, we now know that if we keep the patient on a low dose of HCG, while they're on testosterone, they come back faster. So we like that approach. So any of my men in their reproductive years, we will keep them on HCG at a low dose once a week while they're taking testosterone. And we can get them back faster to where they want to be with sperm production than if they had never taken it.
So my last follow-up question is the following. Do you worry more about side effects when you have someone who's staying on their testosterone therapy, plus you're adding higher doses of HCG and FSH? Do you see higher rates of polycythemia and hyperestrogenism in those patients?
So not polycythemia. The only thing you may see is an increase in their estrogen because HCG stimulates aromatase. But any of my patients who are taking testosterone, I keep on low dose androgen aromatase inhibitor, but at a low dose. So I don't want any side effects. But we keep it low. This keeps their estrogen down, which makes their testosterone all the more potent. And we keep them on that when they start the HCG, and we may increase it depending on what their serum estrogen shows.
I said that was my last follow-up question, but I have one more for you, Dr. Lipshultz, because this is also an age-old question where people ask about, you know, levels of testosterone when people are on therapy. And some people get really worried if they see a testosterone level that's 1200, 1300. And obviously it depends on when you're checking it within someone's cycle. So do you check testosterone in these guys who you're having on testosterone, you know, HCG, FSH? And is there a level that says, maybe we're up a little bit too high? Is there anything that worries you in that regard?
What worries me is the potential side effects of testosterone. The elevated hematocrit, the elevated estrogen, some changes in their lipid profile. So that's what I want to monitor, because my goal is how the patient feels. And if he feels well, then I don't want to start lowering his testosterone to reach some arbitrary limit that's been set mainly by endocrinologists with this morning values, which makes no sense to me as to why we have to measure it in the morning. Because if someone's low in the afternoon, they're low. I mean, you know, it doesn't make any difference what time of day it is. So, no, I don't care that much about the serum testosterone, but and anybody watching this or listening to this, the right answer is you've got to keep testosterone within the normal range, you know, which is 200, 300 to 1,000. But it's very hard to do and make the patient feel well. They will feel better in the higher end of that regimen rather than in the lower end.
Okay, one more question. When you're checking these lipid panels, are you checking a standard lipid panel or are you checking an advanced lipid panel?
A standard lipid panel. You know, because what I tend to see with men on testosterone is that their HDL goes down a bit and their LDL goes up. So I try to do homeopathic things that keep them on krill oil, which I like. It's a shrimp-based, as you know, lipid. I mean, something to keep their HDL up and their LDL down. And I make sure that they watch their diet and also that they do aerobic exercise to maybe raise their HDL a little bit. But those are the things I look at.
Awesome. Well, we just covered some really exciting topics within urology.
Yes, it was a
and
textbook.
Hormone space. We spoke about testosterone and men with a history of prostate cancer, peptides, and the use of testosterone and HCG and FSH in people who were actively trying to conceive. Dr. Lipshultz, it's always a pleasure speaking with you.
Yes, I agree. Nice seeing you again.